Coming up on Why Should I Trust You? Talk to many skeptics today, and you'll hear a familiar story of how they lost trust in public health. They told us not to wear masks, then insisted we must. They said the vaccine would prevent infection, but I got it anyway. They ignored us when we begged for a dying father to be allowed to try ivermectin. And a big thing we hear from public health in their defense, there is no playbook for a crisis like this. But is that really true? Starting in the early 80s, when the first cases of AIDS began to emerge, public health learned from years of trial and error how to communicate during a deadly epidemic, how to acknowledge what you do not know, and how to build trust with grassroots communities instead of fighting them. It even shaped the careers of the very people who led the COVID response, from Dr. Anthony Fauci to Dr. Robert Redfield. So why did public health stumble so badly when COVID hit? Today, we speak with Dr. Reed Tuckson, former Commissioner of Public Health for Washington, D.C. during the height of the AIDS crisis. What did that experience teach him? And could the AIDS era still offer a roadmap for rebuilding trust today? Let's get started. Hey, everyone. Welcome back.
Welcome, everybody.
Hey.
We have a really interesting episode today. One that we've been kind of thinking about since we started up this podcast, Tom.
That's true. That's true.
Yeah, it goes back a while. It's so funny. We only started this podcast in January.
It goes back like 4 weeks.
It's been a decade, right?
It's been 4 weeks. No, I'm just kidding. Hey, 6-month anniversary, man. Not bad. Go watch I Trust You. But today we're going to explore the history of the AIDS crisis in the United States and how it transformed public health in this country. Yet some of the biggest lessons from that time period weren't necessarily applied during the COVID era. And we'll get into that in a minute. But first, who the heck are we? I'm Brenda Adhikari.
I'm Tom Johnson.
I'm Maggie Bartlett.
So Brenda and I are journalists. Maggie is a virologist, and Dr. Mark is off this week.
Yes.
Slacking.
Something summary.
I know. We're going to miss you, Dr. Mark. Okay, so the AIDS crisis. I mean, I was a kid during the AIDS crisis, and Maggie, were you?
Yeah, this is awkward. You guys are calling me out, but nope, I was in the 90s.
Well, AIDS stretched into the 90s.
It did.
Yeah, I remember being, I was growing up in the 80s, went to high school in the 80s, even a little bit of college in the 80s, but it was terrifying. I put it up there with the Cold War. It was just one of those things that just weighed on your parents. I had my neighbor, her brother died of AIDS. My best friend's uncle died of AIDS.
Right.
It was just happening. We lived outside New York City. So, maybe we were seeing this more than other kids growing up elsewhere. But, it was a terrifying, confusing, really, really sad time period.
Yeah. And I think it was also a big part of the sort of cultural moment where there was such a big push for awareness, and there were like concerts and telethons and TV shows that were all featuring this issue. And it was just a part of the public consciousness. It felt like at the time.
And incredible stigmas and
yes,
angers and hatreds. And, it just was a confluence of a lot of things.
Well, listen, it's a lot to explore. And to help us do that, we are thrilled to welcome a friend of the show, the one and only Dr. Reed Tuckson. Hi, yes. Dr. Tuckson.
Well, hello, and great to be with you. And I have to say that you guys are making me feel a little bit old.
You are young at heart and young in spirit. In addition to his time as the Commissioner of Public Health for Washington, D.C. during the height of the AIDS crisis, Dr. Tuckson has held leadership roles at the NIH, National Academy of Medicine. He's worked on the corporate side and industry. He's worked for nonprofits, academic boards. And what's music to the ears of this podcast, he is the co-founder of the Coalition for Trust in Health and Science. Reed, welcome.
Thank you so much. Thank you.
So set the stage for us, Reed. Take us back in time, way before COVID, to America's first real modern day pandemic. Take us back to Washington, D.C. in the 80s and the height of the AIDS era. What lessons did you learn as a public health leader during that time?
Well, first of all, let me take you back a little bit further than even just being the Commissioner of Health in D.C. during the 80s. I remember I was in my training training in internal medicine at the Hospital of the University of Philadelphia in 1981. And I remember diagnosing a gay man who had pneumonia, and along with that, purple, red, and brown little skin splotches that were unusual, that we weren't used to seeing. And what we ultimately came to understand what he had was Kaposi's sarcoma, which was a common sequela of having AIDS. And after a while, we began to understand that this was something new, something different. And we were beginning to then dawning on us that this was a new syndrome that was spreading, and that a new syndrome that was spreading then primarily, we thought, in gay males, until ultimately we found that it was spreading in others. And so this was an unusual, slow-moving train of knowledge. It took many years before we really kind of got our hands around what was really going on here. What it was like being the health commissioner at the beginning or the early stages of this was very, very challenging because of, number one, we had to learn about what this was. And so the science had to catch up to it. Number two, as indicated, once we gained understanding of the population, of how this was spread, that this was spread through very intimate contact between people, although it took a while for people to understand that. So the fear was across the population. This unknown disease, this mysterious new entity, seemed that almost anyone could get it. And therefore, it meant that there was a great movement towards finding people that had it and isolating them away, quarantining people from the general society, because, again, it was felt that anyone could get it. Once we then began to understand that the disease was through direct contact and mainly, again, spread through people who were having sex, men having sex with other men, people that were using IV drugs and sharing needles, and beginning those kinds of intimacies, then the disease spread, the attitude of the public spread more towards this notion of stigmatization. And then it got caught up in all kinds of social challenges as well as political challenges. And so all of those started to merge together to make it very, very complex to get at this.
That's really interesting. I was reading something that Michael Katz, who was maybe your counterpart in San Francisco public health back in the 1990s and worked like you on the front lines of the epidemic. And he was reflecting on sort of lessons for public health and what he learned from that experience. This was before COVID. Back in 2007, he wrote about this. And he said, the AIDS epidemic has proven that the best way for gaining the support of a community is to actively involve them in the decision-making process. And this requires giving up power, something many government bureaucrats are loath to do. But our experience has been that by giving up power, power is gained, the power to forge consensus solutions that marshal government and community forces all behind the same mission. Like, I'm just curious, he's clearly talking about public health bringing into the circle of power, into the conversation with public health, the community that's being, affected by a virus. Is that your experience that was a key lesson from AIDS, that you can do more and have more success by giving up power and bringing in the community? And then I want to follow that up with kind of where that lesson applied in COVID, or was that lesson sort of lost because of different circumstances?
There's no question that this observation that was made in the 90s was absolutely true. I think that we both, first of all, we learned it mainly and in many ways through what Tony Fauci learned during like around 1984 or so. As Tony was moving into running the National Institute of Allergy and Infectious Diseases, he was really very much on the point at trying to find ways for developing treatment. There were the advocacy community, especially from the gay male community, was very, very militant about pushing harder and harder for faster and faster science leading to treatment that would be effective. Originally, there was tension between Dr. Fauci early on and the AIDS activists. However, at the end of the day, Tony focused very much on the science, and public officials was a science-based conversation. There were challenges, differences of opinion around how clinical research was done, how the structures and the bureaucracy of clinical research seemed to make things take too long from the point of view of the advocacy community, because so many were dying and they were dying so fast. And so there was this tension. However, when they got on the same page, because they were both talking about the same goals and they were also talking about the same science, that partnership really taught all the rest of us how important it was. I would say that the other area that I experienced it most dramatically in this country, as you can imagine, there are still tensions around race when it comes to the expressions of being gay. In Washington, D.C., the Black gay community were people that were coming from a very conservative community, very much conservative community. And whereas the white gay community in D.C., most of those people came to D.C. to live their lives, absent of immediate family. And so for the Black community, the Black gay folks were underground very much. And it was very difficult to reach them. And so one of the key points of my commissionership was to be really working at the grassroots community level with the community itself and having the community buy in to taking leadership and having the government sort of almost be supportive of community as opposed to community being supportive of government. And so I think that lesson was absolutely critically important. One other key point, if I may, that has transformed much of the way in which we in health and public health view our role. That was when people were dying from this disease, there wasn't a lot of social support for them. There was not the kind of community-based engagement that we sort of take for granted. So the community, the gay community organized itself to provide people to go into homes and feed people, to buy groceries for those who couldn't get out, to organize housing arrangements for those who couldn't care for themselves. This community-based infrastructure was created by the community itself to serve their folks. And we in government had to find ways to help support that. So that partnership in what we call the social determinants of health now, that movement came, I think, came out of the AIDS fight, as we now have organized communities working across disciplines to be able to support not only the therapeutic interventions, but the medically necessary social supports that also partner with that. And I think that's one of the big learnings that we ought to give the AIDS movement credit for.
Yeah. I'm so fascinated by the idea that, government at the time was there to basically support communities that were trying to help themselves. I mean, it's, I'd love to kind of focus in and hone in on, because what you're referring to is the ACT UP community, of course, which ACT UP stands for AIDS Coalition to Unleash Power. And what I'd love to kind of understand, what did that look like to work with a community that was very critical of the public health response, that was militant, like you'd said? I believe Larry Kramer, its leader at one point, called Anthony Fauci a murderer, and of course on his deathbed told Anthony Fauci that he loved him, which again, that just like blows my mind, that story. But talk to us a little bit about, what did that look like to work with that grassroots community, whether it's ACT UP or others?
Well, it is important to note that the community was not homogeneous, and so ACT UP was on a more on one fringe. I will say that most of the things that I just described earlier in my conversation was actually from the gay community itself, not in an organizational mode.
Got it.
ACT UP. Now, I will say though that the ACT UP movement pushed everybody along, and certainly made government very much accountable. It was not always pleasant. I will say that I remember so clearly that I had the same interests as the advocacy community did. There were almost no areas in my commissionership where I disagreed with any of the things that the advocacy community wanted. However, because they were very much using the tools of theater of drama and so forth. I remember sitting, having a 2-hour meeting with them, talking about all the strategies, and I kept thinking it was such a great meeting. And then they kept pushing me to the point where they finally said something that just really kind of infuriated me. And that was what their photographer was waiting for, and snapped the picture. And that was
Oh
on the
my
front
goodness.
page of their magazine. And that was okay because we knew what the game was. And that was fine because, again, without that kind of militancy, I don't think that we would have in this country moved as rapidly. So there was a variety of ways that people went to work together. But let's also remind ourselves that the ACT UP movement led to some very important things that still exist today. I think one of the things in particular was how the FDA was challenged to change. They shut down the FDA for a day in their protests, but they have definitely helped in increasing the speed in approving therapies. They pushed for the development of better new alternative research designs that were in opposition sometimes to randomized blinded controlled trials, and that when investigators didn't provide the kind of studies that they wanted, they taught people and research subjects how to get their medications tested outside of traditional studies so that we could learn through other mechanisms. So my point being that the ACT UP movement definitely had made changes that were, I think, important and useful at the level of the FDA.
Part of what ACT UP was fighting for was getting access to people who were frankly dying, access to medicines that hadn't gone through the bureaucratic processes to be approved yet, and to speed this up and to, give people a chance at something that was deemed experimental. We were discussing before we hopped on with you, Reed, about, there are some parallels here, possibly with what became the MAHA movement in COVID. There were people who were saying, my loved one's in that hospital ICU, he's dying, I want him to get ivermectin. I know, I hear you when you say it hasn't gone through all the steps of the study. That could be a year or two away. I know that you don't think it's going to work, but we don't have anything else. Could I not get my loved one that chance? But it seems also that the lessons from some in public health, from the AIDS era of work with ACT UP, loosen some rules, give people some medicines, even if it's not proven. That didn't necessarily apply in this when we found ourselves in COVID. Can you think about that and wrestle with that at all? Was it because there was a vaccine and all the energy was get people vaccinated, don't do these treatments? Like, was that it? Or was it just the chaos of COVID being so,
Was it the
sudden?
politics of it?
Was it the politics? Was it?
I think, first of all, I want to be very, again, cautious about what we sort of say about today, but let's give the people credit that were working on AIDS. And that is that they were very much focused on the science, that these were people that were talking the same science as were the
members of ACT UP were part of that. Is
Yes.
that what you're saying? Yeah.
Yes. And it was very much focused on the fundamentals of how T cells worked. They were not intimidated by genetics. They were not, intimidated by the fundamentals of an RNA-based virus. In other words, they were locked in on it from a point of view of science and were much more, even though they were looking to see things tested, they still were focused very much on understanding science in a very serious way. The second thing was that those folks had a political agenda that was very much on not being contrary, but on survival. And so that they would not have been, back in those days, the people that were decrying the use of technology and biotechnology to produce a vaccine that would then be implemented. They were really hell-bent on saving as many lives as possible. There were other agendas that have conflated and challenged maybe some of the modern day COVID activities, but these are very different responses, I would say. Although at one level, the idea of testing alternative therapies, but for real, during the HIV era, it was very much hoping that we could get a vaccine to prevent this disease, not worrying about just all the kinds of ways of treatment. The other thing is that the advocates in the HIV era did not have conflicting economic interests. They were not making any money from their advocacy efforts. They were not offering alternative things that they would want to push forward that could give them a bit of a conflict of interest. And we see a little of that now. Now, I want to be clear and careful. That doesn't, I'm not trying to say that all of the people that are worried about, that are in the, for example, the MAHA movement or the people that were challenging the public health system for COVID, all of them had a financial constraint, but there was a lot of that. There was none of that with the community with ACT UP and those folks. They were just hell bent on finding the best science to take care of saving their people.
Yeah.
What's interesting about that, Reed, is again, just looking at things that have been written about that era. There's one school of thought that says America's fascination with experimental therapies and alternative treatments in many ways was really given like new energy and fuel during the AIDS era, because there was such an interest in like, you know, checking out like acupuncture and herbal remedies and mega vitamins and massages and all of this stuff as like treatments when, you know, I guess there was still the science hadn't revealed the ways in which it could be treated more successfully. So in some ways, you know, when we talk about medical freedom and the right to try and these experimental treatments, that did have a home in the AIDS movement.
Yes.
And it's just interesting. I think what I'm hearing you say is the difference is that there wasn't as much of a fight about the science. That's what I'm hearing you say.
Sure.
Now let's fast forward to 2020. What were the public health folks now up against that was different from the activists, that was different from the folks who were fighting for these experimental treatments and just fighting for treatments to get fast tracked?
Yeah.
What's the difference?
Well, by the way, and to your first point, by the way, that the reason, there's no question that your initial point was correct in that, from my perspective and my experience, that the rise of alternative treatments, when we finally got a therapeutic intervention for HIV/AIDS, AZT, the challenge with it is that it was very toxic. And it was a very difficult drug to tolerate early on. And so the alternative treatments and other modalities like herbal remedies and megavitamins, massages, acupuncture, all of that sort of was brought forward. What was different, I think, in 2020 was, first, we got to remember that the two epidemics were different in terms of scale and in terms of speed. The AIDS epidemic was, even though that we have lost in total 700,000 people, but between 1981 and 1990, it was about 100,000 people died in the U.S. from AIDS. That is too many. That is horrible. That is tragic. But it evolved over a longer period of time. The COVID experience, as you know, hit quickly. It came out of nowhere. It moved absolutely rapidly, and people were dying, very, very quickly at huge scale. As we know now, more than 1,200,000 people in the United States alone. So what we were faced with COVID was the need to respond much, much more rapidly in a much more uncertain way. And then you're responding to a disease that is not transmitted by intimate contact, but in fact is transmitted by just being in the same vicinity as someone and they are breathing on you. So that is a whole different, an entirely different response is required for something like that. And so I think that while you are still learning the lessons, I certainly, in my work against COVID, I went back to my community in DC. And I completely engaged with the community in DC in the exact same way I did when I was the health commissioner. No difference there. But it still meant, though, that we were responding to something that was moving so rapidly, and we had to engage people even before we had enough data with certainty to know all of the ways we had to do. You have to remember also that in both of these diseases, the people that are in public health positions are charged by their mission, by their obligations because of their duty and in terms of their jobs in representing the city. These are people that are absolutely fanatically pressured by saving as many lives as possible. And so you just have to do the best you can, even when you don't have all the information you need to have. And that was the real challenge with COVID in 2020, is because you've got refrigerator trucks backed up to hospitals with the dead being put in refrigerator trucks because there's no more room in the morgues. that requires a certain kind of response, which was a little different than the kind of pressures you were under in the 80s with HIV.
Yeah, fascinating. I remember we were discussing on the podcast the death count from COVID, and it's obviously a hot topic in the world of mistrust. A lot of people, many people during the COVID era, felt there was an overcount of the death toll, and that was used as a justification for government to take a heavy hand in intervention. And I was interested to find that back during the AIDS epidemic, the gay community, for one, really felt there was an undercount of the death toll, and that was being as an excuse for government to do less and have less intervention. I just wonder if you could think and talk about this whole notion of death count and how critical that is for public health, and how easily it is for communities affected to feel mistrustful about the number of dead and what that's leading to in terms of public health response.
It is never an argument that can be won. So it just depends on what your preconceived bias is. You cannot win that argument, and so it's not useful. What is useful is something, for example, in DC. I remember because of the lockdown that communities had, those that were dying were not able to go to funerals. There were not public funerals, and families could not bury their dead very easily. And so after about 9 months or so of the pandemic, I remember what we did was to hold a public funeral for people, and we brought online. It was a Zoom thing with, produced with a TV station and a radio stations all coming together. And it was a Sunday afternoon. And we literally told the stories with the photographs of the people that were dying, and had a family member say, "This is a picture of my mother, and she lived a wonderful life, and she went to this school, and she did this, and now she is gone." And then we would do it. And we spent the whole afternoon just doing that. My point being that it wasn't so much for us about learning about the numbers. It was about the stories of real people that were really dying. And not only did we need to honor them, but we also needed to use their deaths, and what their families wanted was for those deaths to be used as a way of saying to those who were denying that this disease exists, that it was denying that they were at risk, was a way of saying, look, we don't want to lose any more people's grandmothers. Let us tell our stories. It was an incredible afternoon. That was much more important than trying to give people the data.
Mm.
Reed, I think that's such a fascinating perspective to have on this, because I'm from Nebraska, and I remember that was one of the things growing up was you can't get HIV or AIDS unless you're gay. And that certainly is not the case. And as a virologist, I understand all the intricacies now, but I know that stigma really impacted the response to AIDS, and most profoundly, obviously, the gay community and IV drug users, but many other people still got AIDS because it can be, it's bloodborne, right? It's transmitted in different ways. And so what did we learn about allowing stigma into America's response during an epidemic at that time?
What I learned so intimately is that if you stigmatize a disease, you will lead to death. It is an absolute one-to-one connection. I mentioned again and just using the Black community in a city like Washington, D.C., we had the fifth largest AIDS death count, in the country. The Black gay community, because they were stigmatized, because the Black church, especially then, was extremely conservative about gay lifestyles, even though the choir was almost filled with gay people. It was a very strange thing. But that group having to go, for them going underground and not being able to talk about it, because they certainly weren't going to say they were gay when your aunt and your grandmother are still alive, and you walk, and you're going to their homes and for Sunday dinner. That when that happens, it makes it very difficult to be able to reach them. If you stigmatize folks, you can't get at them because they go underground. And if they go underground, then you will spend enormous amounts of time and energy trying to find safe ways of having that conversation. So the stigma is very important. And then secondly, you get the stigmatization that affects the use of public resources or the availability of public resources. Back in the AIDS crisis, Ronald Reagan was during his time as president, and he absolutely was not, willing to acknowledge or be supportive of the gay community in trying to solve this. And that meant that there were other heroes that had to break through. One name that very rarely gets mentioned anymore is Dr. C. Everett Koop, who was the Surgeon General then. Dr. Koop was always viewed by us when he came into office as an enormously conservative person, and he was. But because he was a dedicated scientist, he looked at the data, and after a while, he became one of the best advocates for bringing this into the light of day and caused Ronald Reagan to have to change. I would say one other thing, though, is that if you look at the IV drug abusing population, they certainly are a community, Maggie, that is stigmatized.
Yes.
There is one of the things that COVID has been instructive about is that there is a plurality of values in our country. There are many communities that view things in very in different ways. And so what I'm getting at is, I remember going with the police to what they call jump out squads to go into the shooting galleries where people do IV drugs. And I remember being the health commissioner and riding with them and rushing into these rooms, into these buildings, which are mainly condemned buildings that don't have running water. They've got these IV needles stuck into styrofoam cups, look like a piñata, just all over the place. They pick those needles out of the styrofoam cup and use rainwater or whatever is available to try to unclog the gunk in them, do their drugs, and shoot each other up. It became clear to me after doing enough of that we needed to ideally have needle exchange programs to stop the transmission, which I couldn't get done at that time. But I said, we're going to do bleach. We're going to give out bleach to in all of these places, so at least it can kill off the virus while they're doing whatever they're doing. The media brought me, to a press conference with people saying that I was enabling drug abuse, and that for those who had a legitimate concern about trying to stamp the spread of substance abuse, which is a legitimate concern, they were critical of me. I had the press conference and I asked everyone a question right from the beginning. Have you ever met anyone in your life that if you hand them a bottle of bleach, that they're going to next ask you, where can I get some heroin? It's absurd. And that was the end of the press conference. But what I'm getting at is that you have these stigmatized communities, but you also have a pluralism of values about how you deal with those communities. And at the end of the day, you make judgments that become ripe for great social anxiety and great challenges. And you have to sort of figure out what is your risk tolerance for what outcome versus another outcome? What's your risk tolerance for action versus your risk tolerance for non-action?
Final question here. I wonder if, for closing thoughts, you can share with us, I keep coming back to this idea of giving grassroots activists a seat at the table. The importance of, elevating from a ground up and empowering people to really have agency over their own lives. And I wonder if you think we're doing enough of that in our society today, and whether some of our mistrust and our dysfunction these days, particularly as folks in public health try to reach communities that they're unable to reach, is to kind of reconnect with that mantra. Tell me a little bit about that as we close out here.
It is the most important thing to close out on, and it's sort of where you began this conversation at the beginning. There is no question that we learned how important that was in HIV, and we need to do better at it now. I know that was the model of all the COVID work that I did in creating the Black Coalition Against COVID. The entire model of what we did in DC to fight COVID was based on community leadership. and getting the community involved, picking the community influencers and getting them in the conversation. So, and having them sort of drive it, having our community and faith-based organizations take leadership and deal with their constituencies and teach us what's going on in the community and helping us then to be able to respond. So I am absolutely wedded to it, not only philosophically, but it was the hallmark. I use all of those lessons in the work that we're doing in DC on COVID. I think your point, though, as we close out, is you're also thinking about it more nationally. And are we able to do that with communities who feel very differently about science, with communities who feel very differently about the need for not worrying as much about prevention and more about treatment, alternative treatments that need to be studied and evaluated. That tension is there, and we have to be honest about it. And that's why the program that you're doing, the work that I'm privileged to do in association with you and with others, we've got to find that common ground. We have to find that common ground. But I would say that the most important thing in finding that common ground of the community and the science and public health leadership working together has got to be our shared value on human survival. That's really where it boils down, is we've got to care more about whether we live or whether we die as the fundamental ethic that defines that conversation. And sometimes that is not necessarily as clear as it needs to be. And we have to take time to break bread with others and sit, which is what I'm planning to do in a couple of days. I will be sitting with people that think about these issues very differently than I do. But, we're going to have lunch. And we're going to just...
That's right. I think with some of the Maha, Georgia folks, Reed's taking them out for lunch.
And that's what we have to do, is find a way around breaking bread together and saying, okay, let's talk about each other's lives. Let's talk about your family. Let's talk about where we're really coming from. And if we can get aligned, as we did and as we learned in HIV, it is that this sense that what we all want is to save as many lives as quickly as we can. If that's our ethic going forward, we will find a way forward together.
Dr. Reed Tuckson, you don't disappoint. I'll tell you that. You are a passionate man,
Really
and really grateful for you being here today. Dr. Reed Tuckson, co-founder of the Coalition to Build Trust in Health and Science, former health commissioner for the DC Department of Health during the AIDS crisis, really has just worn so many hats as somebody working in health. We're really just grateful that you joined us on Why Should I Trust You today, and on other episodes as well. Thank you.
I love the podcast. I'm a fan.
Awesome.
So that is our show for today. Please send us questions, comments at questions@whyshoulditrustyou.net. I am Brenda. She is Maggie Bartlett. He is Tom Johnson. And we will see you right back here next week.